Okay, so we're going to have the part 2 of reading the CT scan of the temporal bone and the MRI. So this will be available on Royal Pearl ENT University YouTube channel. Of course, this will be always there, but it has got a privacy policy. You cannot, share it with your channel. That's not possible because it is all the property belongs to Royal Pearl ENT University. So this is applicable for any video. Initially, what happened is when I posted, they were actually putting it in their channel. It's not possible that way. Now, we are going to the second part. Dr. Nilesh, as you saw, was one of the best speakers of temple bone anatomy, the radiological part. And now we are going to go for the pathology. Dr. Nilesh, are you there? So let's wait for him to join. So I'm going to have a few more lectures on sleep apnea. So I've contacted some people from abroad, and that will be sort of, very, very useful. Also, some people in India. I think this is the best lecture in a CT temple bone, which I've seen so far in my lifetime. So like that, we have to have the best in whatever, this channel is going to provide. Dr. Nilesh, are you there? We'll also have some lectures on cochlear implant CT scans and MRIs. So I have also contacted a few people. So they were willing to give lectures on CT with respect to the cochlear implants. Dr. Nilesh G has joined. Over to him. Over to part 2 of reading the CT temple bone. Now you've got a big fan base now, Dr. Nilesh. Everybody is asking about you. This is super duper class. You have to unmute yourself, my dear friend. You can't unmute. Just check. Nilesh. Make him co-host. Huh?
Yeah, now I'm unmuted, sir. Yes.
You're co-host now. Okay. Yeah. So I was just telling the audience that this will be available on our channel.
Yeah.
Many people are asking, please keep it, retain it. Yes, it will be retained. Only thing is they cannot share it to their channels because we have copyright issues now. I have made it copyright, and so this will be there in our channel. Yeah. So, okay, over to you for the part 2. Take your time. No, don't cut it short, because this should be the ultimate reference for anybody, any consultant, PG, whatever. So, if you want to deal with inner ear abnormality, middle ear abnormality, middle ear, whatever, implantology, so you can exhaustively do everything. We are there for you, waiting for you, and waiting to listen to you. Wonderful lecture. God bless you, and carry on, please.
Thank you very much, sir. So we'll begin with our lecture. Yeah, so the next part is radiology of the temporal bone pathologies. So we'll begin with, sir, what are the most important structures in any ear surgery, sir? Need not to be pathologically abnormal, but what are the normal structures which can come in our way of surgery? The most and foremost we are afraid of is the sigmoid sinus, because it is a structure, as we drill in the sagittal plane, that is the first structure we most of the time we encounter along with the tegmen plate. So sigmoid sinus we are very much worried about. Then comes the jugular bulb when we go to elevate the tympanomeatal flap, whether it is high riding or not. Then the few structures, like if semicircular canal is involved, then surgery becomes critical. Then ossicular status, as always, we have to think about the ossiculoplasty. And another structure which you are afraid of is the facial nerve. So if these structures, if in normal case, like say central perforation case or any limited cholesteatoma case, if we are able to make out any pathological or you can say anatomical variation in these structures, our surgery will be easy if you are keeping it in mind. So sigmoid sinus, I told you in the beginning of this normal scan lecture also that the antral place sinus, when to call it and how to label it as well within place sinus. So let me open this. Yeah. So we'll go to the scan. We'll see it bilaterally. So both is here. So we'll see it bilaterally how the sinuses are looking in particular scan, and then we'll see. So now here, as I told you, visually you can compare both the sinuses. You can see here the left sinus. This is the right temporal bone. Just zoom it. So left sinus is well within the mastoidal system. There is lot of space anterior to it, and there is lot of space lateral to it. So this sinus is well within placed inside the mastoid. When you say the opposite mastoid, this sinus, it's the right temporal bone. The left side of the scan is the right temporal bone. It has formed a thumb-like impression. You can see it is literally going like thumb inside. It's going like a thumb inside the mastoidal system. So because of that, what has happened? We just trace it down now. Trace it down and trace it down. So see what has happened. This anterior part also and lateral part also, there is very little amount of bone over this sinus. So this sinus becomes anteriorly placed as well as laterally placed. If you compare to the opposite side of sinus, now see this scan is not at the same plane. Now here you can use your 3D MPR to make it straight. So go in your coronal cut and just try to rotate it so that both should look little similar. Turn this axis also. Yeah. So see now the scan has become symmetrical. It was not symmetrical by default window. Here you can see it has become symmetrical now if you rotate the axis. So this is the flat sinus. There is lot of bone lateral to it as well as anterior to it. But here what has happened? There is hardly any bone lateral to it, and anteriorly also there is less bone is there. It has called thumb-like impression inside the mastoidal system. Then second thing I told you, just draw a line along the posterior part of petrous bone, along the posterior fossa dura, and try to see how much part is protruding out of sinus. So here very little part is protruding out. If same thing you try to apply here, so much large part is protruding out, means this is the anterior placed sinus and even laterally placed sinus. So like this you can make out which is the anterior placed sinus and laterally placed sinus. We'll see few more. These are pictures.
Dr. Nilesh,
Yeah, sir.
what is the significance of laterally placed sinus?
Sir, laterally placed sinus, I will say, are more dangerous than the anterior placed sinus. Because as soon as you start drilling, see, sir, we drill some more this area actually. We drill at the level of the antrum. So what happens? You give 1 or 2 cuts of cutting burr only. That will open your sinus. While anterior placed sinus, you get still lot of bone here to drill, and then you will see the blue lining. In this type of sinuses, what has happened? Suddenly it will open, and this lateral place sinuses are so much dangerous. Now in this particular case only you see, it may be sometimes will be associated with even transverse sinus exposure. So this is the sigmoid sinus, what we saw. Just keep pressing it up to see where is the transverse sinus. So I'm coming up, up, up. I want to see the transverse sinus where it is. So I'm still coming up, still coming up. And here the transverse sinus is normal in this particular case. But whenever you see the anterior and laterally placed sinus, you have to keep watch on the transverse sinus also. Maybe I'll be having that scan, I'll show you. This is another picture. It is not entire scan. This is just picture. So you can see again thumb-like impression inside the mastoid system. This is the disease here, the lateral semicircular canal fistula. So imagine you want to do canal wall down or even intact canal wall. Once you start drilling, immediately you will get this sinus, which will make your drilling more difficult. So you have to be prepared in the beginning only. If you find any difficult, better to do canal wall down in this type of cases. So next, we'll see. This case maybe. Yeah, so laterally placed sinus, the importance, I think with this case we can understand. So I'll just go up. I'll just see where are the sinuses, both sides. So here, see visually also we can make out that this is the flat sinus on the left side. But this side, if you see, this is quite a very highly anteriorly placed sinus. So this sinus, you just keep pressing. You can see there is a thinning in the posterior canal wall. So these are so much dangerous cases because generally we elevate the posterior skin flap. When we do any ear surgery, we elevate the posterior skin flap in the posterior wall of the external auditory canal. So this type of sinus is there. If you try to incise this horizontal incision, immediately it will open. When you are starting the surgery, that time only you will encounter the severe bleeding. Now imagine in this case, because patient was having cholesteatoma, we have done the scan. If it would have been only central perforation and picture like this, you can imagine so much trouble we would have faced during operating this case, just a case of simple perforation. So there is a thinning of this anteriorly placed sinus. And as I told you, once you get the laterally placed also, so now you can see the outer cortex is very thin. So once you get laterally placed sinus, always do make a point that you will trace it till the transverse sinus. So I'll just go up to trace the transverse sinus, and here you can see there is opening in the transverse sinus. So there is no bony covering over the transverse sinus in this case. Why it is important? Because this is the area where we give our periosteal incisions along the linea temporalis. So suppose this transverse sinus, you are not knowing preoperatively that periosteum is a divide of medial side bone. You will give incision here, and what we'll do the transverse sinus will get open. So whenever you get laterally placed sinus, which are more dangerous to drill, always make a point, you will go up and trace for the transverse sinus also. Sometimes even transverse sinus may be also dehiscent. So these cases, you have to avoid putting direct incision over the periosteum. You have to give quite lower incision, and from there slowly you can elevate the musculo-periosteal flaps. So that is the importance of knowing the laterally placed sinus, not only the anteriorly placed sinus. So another case we'll see, so that you will come to know what is called the anterior or laterally placed sinus. So always first thing, open any scan and go and compare both the sides. Try to visually see whether both sides are looking same or not. So again, this scan is not at the same level. Use your 3D MPR. Go to coronal cuts, just rotate. Now both are at same level. You can see both side external auditory canal and the middle ear is seen, both the sides. So fairly enough, same level. Then here you can visually make out actually the sinus is, this is well within placed. Lot of cortex is there. anteriorly also, lot of cortex is there laterally also. Here what has happened? It has almost come to the outer cortex. The cortex is breached here. So this is, and then second point, you can just draw a line along the posterior part of the petrous bone and the posterior fossa dura and see whether it is projecting out or not. It is not projecting out. This side can easily make out. It is called as the, again, thumb-like impression inside the mastoid hair cell system, and it is anteriorly placed and laterally placed. So this is about the sigmoid sinus. So sigmoid sinus comes with the jugular bulb. If you see the prominence in the sigmoid sinus, always you should check the prominence of the jugular bulb. So whatever cases we have opened till now, we'll just check whether there is a jugular bulb prominence or not. So this is the case. Now see here, fortunately what has happened? The jugular bulb has not developed this side. So it is the hypoplastic jugular bulb, this side, though the sinus is so much anteriorly placed. So in this case, it is not there. Then we'll trace the next case. So we'll come to this case. We'll see here, the anteriorly laterally placed sinus associated with very prominent jugular bulb. Now this bulb, when you see, you have to see the distance between this prominent bulb. The first thing you have to see whether there is a distance between this tympanic membrane and the jugular bulb or not. Because if you go to elevate this inferior meatal flap, inferior tympanomeatal flap, when you pull the tympanic annulus from the bony annulus, and suppose if this is dehiscent, what will happen? You will puncture the jugular bulb, and then jugular bulb will start bleeding. So here you can see the tympanic membrane slightly better than the previous scans. You can see the tympanic membrane here, thin gray line, and this is a prominent jugular bulb. So you have to check whether there is a distance between this inferior annulus and the jugular bulb or not. I'll zoom it more. Here there is a fair distance is there. Just go down. There is a distance is there. Go up. Distance is there. Then go down, down, down. Here both are almost merging together. But good thing is that there is a bony covering is there over jugular bulb. So when you try to pull this tympanic annulus from bony annulus, nothing to worry, because here it is still intact, bone is still intact. So this is the first thing you should see in the prominent jugular bulb, that is whether there is a distance between annulus and jugular bulb or not. Second thing, you have to see how much high riding it is, till what level it is going. So this particular case, it is going till the level of the round window. Sometimes you may get, it may reach to the interauditory meatus also. So if it is occluding the round window, again you have to be careful not to meddle too much with this area, because if bulb opens, again it will cause bleeding. Anyway, bulb bleeding can be controlled. It is not like internal carotid bleeding, but still it will take and waste your lot of time during the surgery. So two important points: when you see the anterior placed sinus associated with the jugular bulb, you have to see the distance between the tympanic annulus and the jugular bulb. Second thing, you have to see whether cortex is intact or not. And third thing, you have to see what level it has reached. We'll see another case. This was one more case. So here we have seen the anterior and laterally placed sinus. We'll go down and we'll see what is happening to the jugular bulb. See this jugular bulb? Again, you have to make point that you will check whether there is a distance between tympanic annulus and the jugular bulb or not. So again, tympanic membrane you can able to see there is a distance between these two, though both are merging. The good point is that there is a thick cortex over the jugular bulb, so nothing to worry about in this case. Then when you come up, you see what level it has reached. So here round window is still open, and here it is vanishing. So not much significantly enlarged jugular bulb. Only thing is that though it is very large, the bony cortex over it is intact, and so no need to worry when you elevate the tympanomeatal flaps. So both the cases, fortunately, no major problem will face. So near annulus we saw. We'll see few more cases. So again, same thing. You have to check whether the bony cortex is intact or not. If bony cortex is intact, nothing to worry about the prominent jugular bulb. Now here you can see both the side a very prominent jugular bulb is there. Though sinuses are normal, jugular bulb is prominent. Since the sinus is slightly anterior place, but here you can see the prominent jugular bulb, and here now you can make out this tympanic membrane. On CT scan only you can tell there is a meringosclerosis in this tympanic membrane, because the rest of the tympanic membrane you saw how hard it was to see the tympanic membrane. But here, if you see, the tympanic membrane is very nicely seen. Why it is very nicely seen? Because there is definite meringosclerosis in this tympanic membrane. That's why tympanic membrane is looking so white. So, prominent jugular bulb. The jugular bulb is sitting over the tympanic annulus, but nothing to worry because the bony cortex is intact. Then we'll see next when you should bother in this type of cases. So we'll see the left side. Sorry. Yeah. So we'll see the jugular bulb where it is. See, first of all, you have to see sinus. Sinus again, same thumb-like impression. You can see some thumb is going inside. Okay. You want to put markings, put markings. You can see it is anteriorly placed. Then see the jugular bulb. See this prominent jugular bulb is there. And then we are interested in this part. This area where you are able to see the tympanic annulus and the jugular bulb together. What we are interested in, we want to see whether there is dehiscence in the jugular bulb near the tympanic annulus or the bony annulus. So I am going down. See here what has happened. You can make out that jugular bulb has given a small diverticulum which has come lateral to this bony annulus, the tympanic annulus, and it is lying in the floor of the external auditory canal. So here, before even elevating the tympanomeatal flap, only when you are elevating the skin flap, you will get the bleeding, because the jugular bulb is having small diverticulum here, which has come lateral to the tympanic annulus. So whenever you get the jugular bulb prominence, just check its relation. Don't just keep checking whether it is high reading or not. That is secondary. Because see now this bulb is so prominent, but still it has not reached up to the lower margin of the round window. So that doesn't matter.
Nilesh,
yeah.
In this case, would you like to take a contrast to see if to rule out TPJ?
No, sir. This is diverticulum, sir. Surely this is diverticulum, because TPJ will come from the medial side, sir. It will start somewhere here, and then it will erode this jugulocaroticus septum. And surrounding bone also, sir, if you see, the margins are very smooth, sir. Margins are not like moth-eaten appearance. So if you have doubt, we can get it done. Means contrast can be done, and best is to get MRI with gadolinium contrast, sir. But this is surely a diverticulum which has come lateral to the tympanic membrane, and so you have to be careful while elevating the tympanomeatal flap in the inferior compartment. Then next we'll see. So again, when you get the anterior place sinus, you have to check for jugular bulb. This is very interesting case.
Do you have any grades of grading of jugular bulb?
Yes, sir. There are several gradings.
Grade 1, grade 2, grade 3. Can you elaborate?
Till internal auditory matters, people have given grading, sir. Grade 5, that is called. Sometimes it reaches to oval window, it is grade 4. Then till the round window, grade 3. Lower margin, grade 2. In the hypotympanum, grade 1. Like that, it is defined. But the most important, apart from that grading, sir, which is given in relation with the round window, oval window, and internal auditory matters, I personally think more importance should be given to this tympanic annulus part, sir. Because if jugular bulb is coming till that level, it becomes very difficult to elevate annulus from that side. So you have to be very careful, because even if it is a high reading or going till the round window, oval window, that is in the middle ear, sir. You will not directly touch it. First you will see it and then you will stop it. This inferior tympanic annulus is the area where we don't see it, sir. Sometimes even only blindly we'll try to elevate that part, and if this type of jugular bulb is sitting there, then immediately it will open and rupture. So this case, it is presented with a bluish tinged tympanic membrane. It was looking like something like cholesterol granuloma or hemotympanum. But if you see what is the thing was there, this jugular bulb Here is the jugular bulb. It is entirely dehiscent. There is no bony covering over the jugular bulb, and it is just simply lying in the middle ear. And it was touching to the even the handle of malleus. So it was creating a false impression of glue in the ear. But if you try to do myringotomy in these cases, then accidentally you may puncture this jugular bulb, then it will start bleeding. And it was bilaterally actually. If you see here, this side also it is completely dehiscent and it's just lying in the middle ear. So there is no bony covering over the bilateral jugular bulb. And again, till annulus, fortunately it has not reached. So if you don't do deep myringotomy, still you will be saved once you puncture the tympanic membrane. So this is regarding the jugular bulb. Then next comes the tegmen plate. So we know the triad of contracted mastoid. It's the anteriorly placed sinus, the prominent jugular bulb, and the low-lying tegmen. So when you see the cases where there is a anterior placed sinus, you should see tegmen also, whether it is anterior low-lying or not. So for tegmen, again same principle you can apply. Try to see both the scans together. So again, scan is not at level. You can just make it at level. Go to 3D MPR. Watch on your axial cut. Just keep it at some level where you can make it symmetrical. Keep it somewhere in the this area. Then make it symmetrical and try to compare both sides the tegmen plate. So I told you tegmen plate even you can see in the axial cuts also. So tegmen plate comes here, tegmen plate comes here. So here you can see what you have to see actually. You have to see this middle cranial fossa. This is the posterior cranial fossa. So middle cranial fossa, when it meets to this posterior cranial fossa, you have to see how much descent is there in this. This descent is too much means it is low-lying tegmen, which is easily seen when you see the coronal cuts. So go to coronal cuts. So there visually what we saw that this descent is less than this descent, means left side the tegmen is too much low-lying. According to axial cut also, same thing you have to confirm on the coronal cut. So go in coronal cut, here you can see this is the tegmen. It is the fairly straight away tegmen, but this side if you see it is the low-lying tegmen. Again same principle of drawing line you can apply. You just draw a line along the petrous bone superior margin and just try to see visually how much part is descending. So here very small part is descending, so it is slightly low-lying tegmen. But what is happening this side? Just draw a line along the tegmen and see here how much part is descending down. So it is quite significantly descending low-lying tegmen. So whenever there is an anterior placed sinus, prominent jugular bulb, you have to see for low-lying tegmen also. So what are the other common pathologies? So we finished with the sigmoid sinus, we finished with the jugular bulb, then the tegmen plate, the facial nerve and semicircular canals I'll be covering in these pathologies. So what are the common pathologies we come across in the temporal bone? The foremost is otosclerosis. Why I taken otosclerosis, though other pathologies are common? Otosclerosis is little near normal to the normal scan. Only otosclerotic focus will be there. Rest of the things will be normal in the temporal bone. Then most common disease we come across for which we get CT scan done is the cholesteatoma. Then comes the facial nerve palsy, paragangliomas, and the skull base osteomyelitis. This much pathologies I will try to cover now. So otosclerosis, first and foremost, you should know how the fistula antifenestrum area look. So we'll go to one normal scan. This only will take. Just try to observe how cochlea looks. So we'll see this side. So here you can see the stapes suprastructure is there, the posterior crust, the anterior crust. Change the window, it's too much bright for otosclerosis. Yeah, so now you can see the foot plate, and you have to concentrate on this area. This is the area of interest. It's called fistula antifenestrum. So what you have to see? You have to see lot of scan. You have to remember how this fistula antifenestrum area looks over the cochlea. The cochlea bone looks like this much density should be there in cochlea bone, and the fistula antifenestrum area should be, this triangle should be this much denser. If you see lot of scans like this, then you will remember this. It will get registered in your mind, and any variation from this you can pick up on the CT scan if otosclerosis is there, if otosponiotic focus is there. So see the cochlear density. So normal foot plate, it looks like a thin gray line on a HRCT. Anything more than 0.6 mm, you should suspect the fixation of the foot plate. So this is thin gray line. This is the normal foot plate. This is the normal fistula antifenestrum, and you can see the dense bone of the cochlea over this area. So once you register in your mind that cochlea, fistula antifenestrum, and foot plate looks like this, you see 100 scans, register in your mind that it looks like this. So any variation from this, you can immediately pick it up. So see here, what has happened? Foot plate has become white. It's not thin gray line like this. It has become white. Even visually, you can make out this is thin, this is thick. And then what has happened to the fistula antifenestrum? There is a otospongiosis on this area. You can easily make out the otospongiotic focus. The cochlea, the anterior part has lost its density. So it is a otosclerosis case. Radiologically, more precisely to be called otospongiosis, because it is not sclerotic. Sclerotic means it should be more denser than surrounding bone. But radiologically, it is called as otospongiosis, and clinically we call it as otosclerosis. So this is the spongy bone. It will be less denser than the surrounding bone. So there is a focus of otosclerosis. There is a thickening of the foot plate. Foot plate has become white instead of gray. There is a big focus is there. So same thing you can see in the scan also. We'll just open the scan. So here you require the ideal windows, because sometimes in bone window you may miss this. I'll come to that later. I'll just show you how you can miss that. So here, come here and see here, the density of the cochlea is lost. The bone has become spongy here. The bone is spongy here. Also the foot plate has become thick. It has become white. It is not the regular thin gray line. So what you can do, you can just measure the foot plate also. So you have to take this margin and take this margin and just see how much it is. So it is definitely more than 0.7 mm. So that fix up in our criteria that foot plate may be fixed. And anyway, here even the otosclerotic or otospongiotic, to be more precise, focus is also seen. So what happens if you see in normal bone window, you are not able to make out anything in this scan. This is the default window which is given by the radiology center. So you will easily miss this otosclerosis in this case. So you cannot make out anything in this scan. But if you use the ideal settings, you will be able to make out the otosclerotic focus or otospongiotic focus more precisely. Then visible otospongiotic focus at fistula antifenestrum. We saw this is the normal thin gray line foot plate. The density of the cochlea is intact. Here you can see the foot plate has become white. There is a big otospongiotic focus over the fistula antifenestrum. If you see, this is the posterior crust and this is the anterior crust. So at the base of anterior crust will be fistula antifenestrum, and it has become otospongiotic bone here. Then the focus of otosclerosis again, the thin gray foot plate, the cochlear density is maintained. Here you can see the foot plate has become white. This is the posterior crust, this is the anterior crust. At the base of anterior crust there is otospongiotic focus, and this focus has even involved the middle and apical term of cochlea. Then cochlear otosclerosis. So cochlear density you have to see around the cochlea also. Here you can see the cochlea is nicely dense here. What has happened here? It has formed the otospongiosis all around the cochlea. It is looking like a fourth turn of cochlea. It is also called as fourth ring of cochlea. So cochlear otosclerosis, it has involved the entire cochlea, the basal turn of cochlea. The apical turn is also open. There is a otospongiosis in the fistula antefenestrum, and even foot plate also, if you see, it is not like thin gray line. Though it is not white, entire foot plate has changed to the otospongiosis. So this will be like biscuit type of foot plate with big otospongiotic focus with fourth ring appearance. Then you have to look under correct zoom and correct window settings so that you will not miss the focus. This is what I was telling you. So we'll go to any scan. That scan only will take what I opened. This I'll just close.
You know, manual understand. You should not see this.
So this is the scan. See here, otosclerotic focus, otospongiotic focus is very nicely seen. But if you go to default window, see, you will miss this otospongiotic focus then. You go to full dynamic window or default window. Default window, you are not able to see that much clearly. But you keep the preset settings, then you will be able to identify it. So these two scans are of same patients. This is overexposed film, you can say, where the cochlear density is increased too much. Because of that, what has happened, you are not able to see any otospongiotic focus at fistula antefenestrum. Also, you are not able to see anything periphery of the cochlea. But if you use the correct window settings, you are able to make out the foot plate is white. Then there is a focus of otosclerosis over the fistula antefenestrum, and there is a mild ring is appearing. It is the early cochlear otosclerosis. Again, it is divided in grade 1, 2, A, B, C, 3. So that you can read. It's available on internet also, when to call to A, to B, to C. So then next, even otosclerosis can involve even the semicircular canals also. So semicircular canal involvement is not mentioned in the cochlear otosclerosis because it includes only cochlea. The grading of CT grading of otosclerosis, it has included only the cochlear otosclerosis and not the otosclerosis involving the semicircular canal. So sometimes otosclerosis can be so advanced, it may involve the semicircular canals also. So this you can see the lateral semicircular canal. Here this is the normal actually. Normally lateral semicircular canal looks like this. Here you can see there is lot of spongy bone is formed in the lateral semicircular canal. So this is the otosclerosis where it is a far advanced otosclerosis. It has involved the lateral semicircular canal also. Then you should look for the involvement of the round window also. So round window, we see the dark structure below the promontory and it should be totally dark. Totally dark round window means normal round window. And if otosclerotic focus is involving a round window, it will look like this. It will not remain dark. It will become white like this because otospongiosis will involve the round window also. So whenever you are seeing any scan of otosclerosis like this scan, so when you are seeing the scan, always give importance to round window also. So you will see in this scan what is the status of round window. So see the round window here, it's absolutely normal. It's totally dark. So means otosclerotic focus has not involved the round window. Next comes the facial nerve position and the dehiscence. So facial nerve, we were seeing the facial nerve in the coronal cuts. First we'll see in the axial cut only. So this is the axial cut. So once it comes out of the internal auditory canal, this forms the labyrinthine segment, and then this forms the first genu, the geniculate ganglion, and the horizontal segment. So whenever you see this horizontal segment, there should be significant distance. Now I'll turn to bone window. Whenever you are looking at this horizontal segment, there should be significant distance between this horizontal segment and vestibule. See, vestibule is here and a horizontal segment is here. And when you go down, both should get separated from each other. There should be distance between the horizontal segment of the facial nerve and the vestibule. That means the fallopian canal is normal. It is not overriding the foot plate or the vestibule. There should be distance between horizontal segment and the vestibule. Same you can see on the coronal cuts. So I'll go to coronal cuts. So here again, the cobra sign, nicely you can see the cobra sign of facial nerve. Medial is the labyrinthine segment, lateral is the horizontal segment. So I'll zoom it. So we have to trace this tympanic segment or the horizontal segment, what is happening to it. So I'm going down now. See, it's moving laterally. Here it is. This is the vestibule and this is the horizontal segment. So what happens, this horizontal segment goes along the lateral semicircular canal. This is lateral semicircular canal in the coronal cuts. So here is the facial nerve, this is the vestibule, and this is the horizontal or lateral semicircular canal. So it keeps moving away from the vestibule, this horizontal segment, because by anatomy we know it goes along the lateral semicircular canal. Then it will become the vertical segment later. So this is the vertical segment. Here is the vertical segment of the facial nerve. So there should be distance between this vestibule and this horizontal facial nerve. Then only you will be able to see foot plate properly, and you will be able to make out the, or you will be able to make the fenestra in the foot plate. Suppose if it is running exactly in the center or some abnormal position, then it becomes difficult. So this is, we saw how normally it looks. And in this case, you can make out here, see this facial nerve, the tympanic segment, it is away from the vestibule. This is the vestibule, this is the lateral semicircular canal, it is away from the vestibule. Here what has happened, the upper margin is free, there is no any soft tissue here. Then where does the facial nerve is there? Then this is the vestibule, and here down you can see here over promontory, this is the promontory, and even down will come round window. So here facial nerve, instead of being in the fallopian canal, it has come down and it is lying over the promontory. So we'll see it in scan so that it will be understood more. Facial nerve position, yes, this one. So first we'll trace in the normal side. I think this is normal side. Let's check. Okay, so I'll go in the internal auditory meatus. So this is the internal auditory meatus, labyrinthine segment, first geniculate ganglion, and horizontal segment is coming, and there is a distance between vestibule, that is the foot plate, and the horizontal segment. This is the horizontal segment, this is the foot plate. So there is a distance between these two, though few millimeter, but distance is there, means this facial canal is normal. And similarly you can see in coronal also. So coronal will see same. So go and find your cobra sign. So internal auditory meatus, yeah, cobra sign. So we have to trace this part. So just tracing it down. It's moving away from the vestibule. This is the vestibule. So there is a distance between vestibule and this part, though few millimeter, but it is moving away. And it is moving away with the lateral semicircular canal. So there is a good distance, and then it forms the vertical segment. What is about the left side? We'll see the left side, what is the condition. So again, go and find the internal auditory meatus. So internal auditory meatus. And then here should come out the labyrinthine segment. So labyrinthine segment came out, and then it is taking turn. It has formed the geniculate ganglion, and then it is coming down. But instead of going in this direction, it should have gone lateral to the vestibule. It is what is happening. It is running over the vestibule. It is coming towards the vestibule. See, it's coming towards and running over the promontory. This is the promontory. By this time, this is the pyramid. Your facial nerve should have come here somewhere. There should have been some facial nerve canal here. But instead of coming there, it is running over the promontory. It's still running over the promontory, and even it is covering the round window also. So it has covered entirely the round window. And then it has gone towards the stylomastoid foramen. Same thing you can see in coronal also. So in coronal, try to find out snake eye. So here somehow snake eye you can make out, because this tympanic segment is low lying, it should have been somewhere here. So this tympanic segment, just trace it where it is going. See, this is the vestibule. It should have been gone in this area somewhere in the upper margin, but it has come in the vestibule, and from there it's running down. It's running down the promontory. It is not going along the lateral semicircular canal. It should have been here. Plus, in that, the worst thing is that it is dehiscent totally. See, there is no bony covering over that. Bone is not there over the facial nerve. So it is entirely denuded nerve, and it is running over promontory, and then again it is covering the round window also. This is the round window. So it is entirely covering in the round window and then going in the neck. So this is the anomalous course of the facial nerve. So this type of cases, you cannot get exposure to the foot plate. You will not able to do stepidotomy in this type of cases. So you have to do something else like BHA you can try in these cases.
Dr. Nilesh,
Yes, sir.
can we just look for the persistent stapedial artery? Do you have any scans?
Yeah, sir. Persistent stapedial artery I have seen recently. I think it should be there. So persistent stapedial artery, it comes from the internal carotid artery, sir. So I think this should be there. So persistent stapedial artery, how to trace it, sir? You have to go in the vertical petrous carotid. From there, it will be coming out of like offshoot. It will run over the, it will run inside the eustachian tube orifice. It will run over the promontory. Then through the stapes arch, it will enter the facial canal, sir, ultimately. So this side, I think right side was persistent stapedial artery. So we'll see the foot plate. Here you can see some structure over the promontory. Now you have to identify whether it is a facial nerve or it is persistent stapedial artery, because both are soft tissue structure. So first and go confirm whether facial nerve is there or not. So we'll come to facial nerve. So this is the interauditory meatus, labyrinthine segment. Then the first genu, the horizontal segment. Horizontal segment is moving away from the vestibule. Here it is. Then it's moving down, 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 and then stylomastoid foramen. Means facial nerve is normal. So this is some other structure. It is not facial nerve. It cannot be facial nerve. So this you have to trace where it is going or where it is coming from. So this structure will just trace it where it is going. So we will trace it first up. Like I told, it enters the facial canal. So this soft tissue structure will blend with the facial canal, horizontal facial canal. So here it is blending with the horizontal facial canal. And then if you trace it down, it keeps running over the promontory. So it's running over the promontory. Then it goes anteriorly, because ultimately it should reach to the internal carotid artery. So it is going anteriorly, anteriorly. It's going anteriorly. Just trace it where it is going. See, it has entered inside the internal carotid artery. So this was the.
Can you show us the foramen spinosum in this case? Absent foramen spinosum.
Sir, that need not to be necessarily always true, sir, because in this case, though the persistent stapedial artery is there, you can nicely make out that foramen spinosum is still patent, sir. So if the foramen spinosum is absent, you cannot cauterize the persistent stapedial artery. If foramen spinosum is still patent in presence of persistent stapedial artery, you can just cauterize it, because it will have another branches coming from the foramen spinosum. Because here if you see, though it's persistent stapedial artery, this is the foramen oval here, and foramen spinosum is still present, sir. Round structure is still present. I think bilaterally if we see, because it was unilateral persistent stapedial artery. Yeah, it's unilateral. So
foramen spinosum is present.
oval and foramen
Yeah.
spinosum. This side also
Yeah, we saw it.
foramen oval and foramen spinosum. Both
Yeah.
are present, sir.
Yeah.
It's not always necessary that it will be absent. Few cases you get persistent stapedial artery with the intact foramen spinosum also. So next is, sir, in any case of otosclerosis, you have to keep in mind even ossicular anomalies also. Sometimes you may misdiagnose it as otosclerosis. When you open inside, you see the ossicular anomalies. So ossicular anomalies also can be easily picked up on the CT scan, because you know all the appearances of the ossicles, how they look in the CT scan. Like ice cream cone, we know the molar tooth appearance, we know how the stapes suprastructure looks. So we'll see this scan. And young age group, you have to particularly remember that all cases will not be otosclerosis. It can be congenital anomaly also. Now in this case, you see the age of patient is 15 years. So whenever you see 15 years of age, otosclerosis becomes secondary diagnosis. Primary diagnosis becomes the ossicular anomaly. So we'll go in the EP tympanum to see the ice cream cone. So here, see, the ice cream cone is not that much well seen. See, head looks okay, but body, instead of being triangle like this, it has become triangle like this. So there is a dysplasia of the body of incus. Plus there is a one separate bone over the lateral semicircular canal which is fixing this bone. Means it is not proper ice cream cone appearance. You can say the ice cream cone is distorted here. Means like head of malleus, the body of incus, short process of incus, ice cream cone should be like this. Here what has happened, this has turned like this. It's turned like this and it is completely distorted. It is not normal. Plus there is some bony fixation between the lateral semicircular canal and this body of incus, which is also dysplastic. And when you trace it down, the long process, you see stapes, there is no crus, means there is a single crus, no two crura. So you can see there is a single stapes crus. It is called monopodal stapes. So there is a hypoplasia of the stapes. It's a monopodal stapes. There is a dysplasia of the incus, which is fixed to the lateral semicircular canal. Head looks okay.
Dr. Nilesh,
Yes, sir.
see this monopodal stapes appearance we have seen in many cases. In the sense the anterior crus is not seen.
Yeah.
So how do you confirm, say that this is definitely only one crus? Well, anterior crus sometimes not seen, boss.
On a CT scan or surgically you are telling, sir?
CT scan.
No, sir, that depends on your window settings, sir. I told you, na, sir, you can say almost 50% of the time, it's difficult to see the anterior crus. I'll just show
Then
you.
how do you confirm and say it is monopodal?
No, sir, then you have to change the window settings. See, now in this only we'll try to see both the crusts are seen or not. If after changing,
sometimes it is seen, sometimes it's not seen, boss.
No, sir, that's what. See here, now here you are able to see the posterior crust. Anterior crust is not seen only. So what you have to do, you have to change the window setting. You just check in all window settings if you are able to see any other structure. And if you are not able to see, and sir, monopodal stapes will be something like straight, sir. It will not be like posterior crust and then anterior crust separately.
Okay.
So here only the posterior crust is seen. I changed the window setting almost to all possible settings, but still the anterior crust is not seen, like you told in some cases. But sir, the monopodal stapes should be straight, sir. It should be straight single crust, like a pillar. It will not be like head and then the posterior crust. So it should not be arch like this. Maybe this anterior crust is so much thin and this 0.6 mm, maybe it is less than 0.6 mm. That's why the cut is not showing this. So the monopodal stapes should be exactly straight, sir, like a pillar and not like the arch like structure, either a posterior crura or anterior crura. So this is ossicular anomaly. I think in that case, even it was bilateral. So we'll see the right side also, or left side also, right, we saw already. So again, come to the EP tympanum and check the ice cream cone appearance, how it is. So see here again, ice cream cone is not well appreciated. It has become something, ice cream is there, but cone is completely distorted. Then you come down tracing and see again, this is monopodal stepes. It is a single vertical strut over the stepes foot plate. It's not like any arch-like structure of posterior truss or anterior truss. So this is the monopodal stepes. Then comes the internal auditory matrix diverticulum. So this is something interesting. It's seen in very few cases. You have to be very keen to see this. What is this actually? So this is something which is comes in the anterior-inferior part of the internal auditory matrix. This is called the internal auditory diverticulum. So go to the internal auditory matrix. First, let's see the normal internal auditory matrix. Right?
Now, tell me the width of the internal auditory matrix and comparative width of the vestibular aqueduct. All that can you tell? Because one of the delegates were asking.
Sir, width all depends on the axis of your scan, but it will be 3 to 4 mm in the internal auditory matrix, and the different level you can see it will be different, sir. The instead of and visually you should be able to make out, sir, that whether that is hypoplastic or normal internal auditory matrix. Then this this vestibular aqueduct will be very small. You have to zoom it and just check. It will be less than millimeter, like 0.5, 0.6 mm.
When do you call it dilated?
Sir?
When do you call vestibular aqueduct dilated?
Sir, whenever it is more than 1 mm, 1 mm it is dilated, sir. But whenever it will be dilated, surely it will be more than 3 to 3.5 mm, sir. I'll show that scan. I have one scan. This internal auditory matrix, you can say on scan, it will be like 3 to 4 mm. Out of this, the cochlear nerve will be the biggest nerve, sir. The cochlear nerve diameter varies from 0.9 to 1.3 mm. That will be the biggest nerve in the internal auditory matrix. Second comes the facial nerve, sir, which will be 0.8 to 0.11 mm. Means 0.8 mm to 0.11 mm is the diameter of the facial nerve. The diameter of the cochlear nerve is biggest. It is from 0.9 mm to 1.3 mm. And vestibular nerves, the superior and inferior, we cannot differentiate on the scan. Means on the CT scan also, even on MRI, you cannot differentiate it. Most of the time, both will be merging together. So that will also be somewhere around like the facial nerve. So whenever you see the internal auditory matrix, the biggest nerve should be the cochlear nerve. If cochlear nerve is not the biggest nerve in the internal auditory canal, means there is a hypoplasia or aplasia of the cochlear nerve. So that I'll show you in one MRI actually, because CT is not the proper way to measure the diameters of the cochlear or the facial nerves. So I was at the internal auditory canal diverticulum. So this scan, this diverticulum. First, I'll show the normal. So I was showing you the internal auditory matrix here. Just delete this. So when you trace the internal auditory matrix, this is the internal auditory matrix. So keep watch on the anterior margin of the internal auditory matrix. This is anterior margin. See, this anterior margin is totally intact. It's totally intact. Okay, there is no any bulging in this anterior margin of the internal auditory matrix. What is internal auditory canal diverticulum? I'll take one side at a time. So we'll go to internal auditory matrix and we have to trace the anterior margin of internal auditory matrix. So this is the anterior margin of internal auditory matrix. In its inferior part, we get outpouching of this internal auditory matrix. See, there is a small outpouching here. So this is called the internal auditory canal diverticulum. So this is internal auditory canal diverticulum. Literature says this type of cases, when associated with the otosclerosis, later in the life are more prone to form the or to develop the sensorineural hearing loss. But very few articles are there. It's not hard and fast rule that if internal auditory diverticulum is there, you should not operate. It is not hard and fast rule. But according to the available literature, this internal auditory canal diverticulum, whenever presents, these patients after stepidotomy are more prone for developing the sensory neural hearing loss. So this is the left side, and even in right side also we can trace. So this is the anterior margin of the internal auditory canal, and you can see a small outpouching from there. It is the small outpouching of the internal auditory diverticulum. So this we saw otosclerosis. Facial nerve position I told. Yeah, this is the enlarged vestibular aqueduct. So you can see here, sir, the vestibular aqueduct, visually it should be less than 0.6 mm. But here you see, it's totally anomalous here. You cannot make out a single structure here. The vestibule is quite prominent here. And the vestibular aqueduct is totally dilated. So if you try to measure it, it will surely come more than 3 or 4 mm. So this is called as a vestibular aqueduct enlargement. It will be most of the time will be associated with other type of inner ear anomalies. I have not seen yet only vestibular aqueduct dilation without any inner ear anomalies. The few cases which I have seen are associated with the inner ear anomalies. So this is the dilated vestibular aqueduct. And what about the cochlear aqueduct? So cochlear aqueduct, it is a debate, matter of debate whether dilated cochlear aqueduct exists or not. There are few articles saying that the cochlear aqueduct dilation is a misnomer. There is no such entity. So till now, after seeing so many scans and inner ear anomalies also, I have personally not seen any cochlear aqueduct dilation. So I am also same opinion that there is no such entity like cochlear aqueduct dilation. Only duct dilation can happen in the vestibular aqueduct. Cochlear aqueduct, I have not seen it. In otosclerosis, always you have to keep one thing in the mind, that there is something called infraradiological otosclerosis. Means scan will not be showing any type of otosclerotic focus. It will not show any thick footplate. Footplate will be thin gray line. Still patient will be having mixed lobes or conductive hearing loss. Your clinical diagnosis say it is otosclerosis. So do open these cases and you have to do stepidotomy in these cases, because stapes footplate will be fixed in these cases, though not picked up with HRCT temporal bone, because there is something called infraradiological otosclerosis. You have to make your radiologist also aware. If you are referring any cases of otosclerosis to them for the scan, and if they do not find any type of otosclerosis or footplate thickening in the scan, they should always put this wording: radiologically undetectable otosclerosis can be a case of infraradiological otosclerosis. If they straight away give a report of normal HRCT temporal bone, then patient will come and then surely they will ask you what type of surgery you are planning in me, when the scan is saying everything is normal, that footplate is also normal, they will label sometime. So you have to always make your radiologist aware to mention it as an infraradiological otosclerosis. Then next we'll see the fissulas of the semicircular canal. So here you can see there is a fissula over the dome of the lateral semicircular canal. This is the canal wall down of the right ear. You can see stapes here, stapedius tendon, footplate will come here. This is the ampullary end of the lateral semicircular canal, and there is a fissula, small fissula. So the lateral semicircular canal normally should look like this. The dome will look like this. There will be cortex will be intact over the lateral semicircular canal. But when you see bridge like this, means there is a fissula in the lateral semicircular canal. So this is the same case where it was over the ampullary end. So this is the ampullary end of the lateral semicircular canal where there is a small dehiscence in the bone. So same thing you have to confirm on the coronal scans also. So in coronal scan, you can see the bone intact over the lateral semicircular canal. But when there is a fissula, you will see breach in this cortex, and it is surrounding with some soft tissue. So there is a breach in the lateral semicircular canal. So this is a small fissula. Sometimes you get a very long linear fissula also. So this is again right here. You can see the fissula is extending from here to here, and membranous labyrinth is intact in this part. So when I am touching the stapes suprastructure, you can see movement of the fissula here. So when you get this type of fissula, you see it is over the dome. So dome should look like this, the intact dome. Here the dome is breach. So there is a breach in the cortex of the lateral semicircular canal surrounding with soft tissue. Clinically, we diagnose it as cholesteatoma. So because of cholesteatoma, there is a fistula of the lateral semicircular canal. Same again, you have to confirm on the coronal scan. So the thick cortex is present like this. Here there is a breach in this cortex of the lateral semicircular canal. It is exposed and dehiscent. Always you can, and also you can see in this case there is a tegment dehiscent because obviously it was a cholesteatoma case. It was eroded the tegment also. Then posterior semicircular canal fistula. It's very rare to see the posterior semicircular canal fistula. Most of the cases I have seen maybe some 5 or 6 cases only. The posterior semicircular canal fistula. Those were the not because of any disease like cholesteatoma or keratosis. I have seen because of the iatrogenic injury in the cases of iatrogenic facial nerve palsy. So posterior semicircular canal looks like this in the axial cut. But here if you see the ampullary end is seen and the non-ampullary end is eroded here. Eroded means it was injury, iatrogenic injury, because you can see the facial nerve is entirely exposed here. Here comes this is the horizontal segment of the facial nerve. Here comes the second genu. From second genu down, the facial nerve was completely exposed, as well as the this posterior semicircular canal also was exposed. Because if you know the anatomy of the facial nerve, the vertical segment of the facial nerve comes in very close approximation to the non-ampullary end of the posterior semicircular canal. So this was eroded or damaged in the iatrogenic injury because the posterior semicircular canal should look like this. Same you can see in the coronal cut. So in coronal cuts, it looks like some C type of structure, the posterior semicircular canal. But here the C was exposed, means posterior semicircular canal is damaged. Then I told you there can be the iatrogenic injuries. So whenever you see iatrogenic injuries, in the injury with the disease or exposure with the disease, you will not see any air shadows inside the vestibule or this labyrinth. But in case of iatrogenic injuries, you may see the air shadows within the labyrinth. So this is the case of iatrogenic injury. You can see a lot of air shadows within the soft tissue. Sometimes some pus pocket may form here, and there is a air shadow inside the labyrinth. Then transverse fracture can involve the labyrinth. Here the vestibule is fractured. The fracture line is running from the posterior fossa dura. So nowadays radiologists, they don't classify the fractures as longitudinal and transverse fracture. They were classified as otic capsule involving and otic capsule sparing fractures, because most of the time we get multiple fractures. One will be looking longitudinal, one will be looking transverse, then will be confused what to label it as. So the simple is to mention the involvement of otic capsule. If it is otic capsule sparing, then label it as otic capsule sparing. If any labyrinth is involved, then it is otic capsule involving fracture. Then sometimes you can see the erosion of cochlea also because of disease process. This was the case of extensive keratosis obturans, where the tympanic plate is completely eroded here, and you can see the basal turn of cochlea is also exposed here. Then sometimes vestibule also can be involved. Again, this is the iatrogenic injury. You can see the vestibule is filled up with air. There is a air inside the vestibule as well as the lateral semicircular canal. Then next comes the ossicular status. Because we have to do ossiculoplasty, we should know what ossicles are present or not. So ossicle wise, we have seen how ice cream cone looks, how to trace the handle of malleus and body of incus and all those things. So in this case, we'll just quickly revise it, how normal looks. So keep concentrating on this right side. So the handle of malleus here. So tip of handle of malleus, neck of malleus, head of malleus, body of incus, then press down the long process of incus. So trace down the long process of incus. Yeah, then double dot sign. Zoom it more. So double dot sign, lenticular process of incus, head of the stapes, both are merging together or not, both have merged. Then to stress stapes, you have to come up. So I'm coming up, but stapes is not seen. So you have to change window settings first to see whether stapes is there or not. So here faintly you can see the posterior crus and anterior crus is there. So means stapes is there. And the IS joint is intact. So this is the normal side. We'll see what has happened to other side, that is the left side. So we'll come up in the epitympanum. So you can see the head of malleus, body of incus, short process of incus. But body, this bone part, this is eroded or necrosed. It has eroded from this side, and then just stress the long process of incus. Long process of incus is absent, and try to change window setting to see if any stapes is there. So stapes is also not there. So here in this case, the long process of incus and stapes suprastructure is absent. For this, you can use a special type of reconstruction. It's called as MIP. MIP means it's a maximum intensity projection. Sometimes in some softwares, you can get it MIP here also as an option. I think here it should be there. Yeah. No, not in this. Horos, you are having option of MIP also. So MIP means what it will do, it will take multiple cuts of 0.6 at same level, and it will club together all to increase the thickness of that bone like this. So this is called maximum intensity projection. Here you can see the multiple cuts are placed over each other, and they will try to form the ossicular chain like this. So the malleus head, the neck of malleus, the handle of malleus, the IM joint, the body of incus, short process of incus, long process of incus, very nicely seen here. Like this, you cannot see in the axial cut, coronal cut, or sagittal cut anywhere, because the MIP means they will club together multiple cuts, and they will increase the thickness of the scan, and then they will make the bones thicker. Like this also, stapes also they can form. See, I told you the faintly I could see in the axial cut, but here it is even more clear, the anterior crus and the posterior crus. Anterior crus, posterior crus is there. So the ossicular chain, intact ossicular chain will look like this. You can see the long process of incus, even the lenticular process of incus also, they are reformatted. Plus stapes head with the crura. What has happened to the left side? See, the handle of malleus is absent, the long process of incus is absent, and stapes they could not reformat because stapes was absent. So like this, you can assess the ossicular chain status so that you can plan for what ossiculoplasty you are going to do in this particular case. Next comes the facial nerve. So horizontal segment, there is an anatomical variation. In 30% of the cases, it may be dehiscent. So it comes into the picture in cases of AOM. So suppose if patient is presented with pus in the middle ear with facial nerve palsy, the first diagnosis should be dehiscent horizontal segment getting compressed because of the pus and surrounding inflammation. Other parts of the facial nerve can be involved in the post-traumatic facial nerve palsy. In cases of cholesteatoma keratosis, the facial nerve schwannoma and the tumors. So post-traumatic facial nerve palsy, we have to trace the fracture line. Then we have to come to know which is the involved segment of the facial nerve. Then any other vital structures, like we saw in that one transverse fracture where the vestibule was involved. Then you have to assess the ossicular chain status also. So we'll see this scan. First we'll see clinical picture, how it was looking. So this is the clinical picture. So this is the post-traumatic facial nerve palsy. Patient presented with this type of endoscopic picture. You can see the retracted eardrum with some hemotympanum and glue formation in the middle ear. You can see the handle of malleus. You can see head is slightly anteriorly pushed because head should have been here, but it is anteriorly pushed. Why it is pushed? There is a fracture between neck of malleus and handle of malleus, and incus is absent. Incus is not present in the artic here. So this was the clinical picture. So we'll see, and patient presented with grade 5 facial nerve palsy. So we'll see what is the scan in this case. So we'll go in the upper part and we'll see the internal auditory meatus because we want to trace the facial nerve. So here is the facial nerve. So internal auditory meatus, the labyrinthine segment, till early labyrinthine segment, it looks okay. As soon as the facial nerve is coming out of the labyrinthine segment, you can see soft tissue density with multiple bony densities inside within, and it is sitting over this area. So this is the culprit here. It will form the organized hematoma because of the rupture of the small capillaries in the this mastoid aeration, at which will form the organized hematoma. This bony specule, everything will be compressing over this area. That is the first genu and geniculate ganglion area. So you can see here nicely the geniculate ganglion is how much it is bulged. The horizontal segment, the bone over the horizontal segment, you can see it's totally intact. Until second genu, it is intact. So there is a fracture line which has involved this perigeniculate area. We call it as perigeniculate, means geniculate ganglion, the first genu, the GSPN, and early labyrinthine segment. So it is compressed here in this case. And what has happened to ice cream cone? See, the ice cream is lying here and cone has pushed laterally. What we saw in the clinically also, and there was a fracture between the neck. This is the neck, and there was a fracture between neck and handle of the malleus. So handle is here, and you can make out small fracture is there between the neck of the malleus and the handle of the malleus. Then any other vital structure is involved here. We'll just see through the labyrinth. Labyrinth looks okay. Okay. Yeah, the fracture line which is coming like from posterior part, it is traversing through the jugular bulb as well as the internal carotid canal. So this is the vital structures which are involved in this particular case. Rest labyrinth and otic capsule is intact. So transverse fracture we already saw, it was going through the vestibule. Then cholesteatoma or keratosis. So cholesteatoma we can diagnose clinically, or if you are having doubt, you can just get DWI imaging, non-echoplanar done. So this is the case of extensive keratosis obturans. So clinically, we were not able to see any anatomical landmark inside. Everything is filled with this keratin material. Extensive keratosis was there. Somewhere here granular meningitis was there, but entire all landmarks are lost in this case. So this is the case of extensive keratosis obturans. So we'll see scan of this patient. See, this is the extensive case. The entire lateral part of temporal bone is involved. There is a defect in the sigmoid sinus plate, the lateral semicircular canal, the dome of the lateral semicircular canal is gone, and the facial nerve, the labyrinthine segment looks intact. Labyrinthine segment looks intact, first genu looks intact, but later it is merged with the surrounding soft tissue. So horizontal segment is not seen entirely. Even vertical segment, now here it is started seen, the vertical segment. This is the stylomastoid foramen. The distal vertical segment is intact, but the proximal vertical segment, the second genu, and entire horizontal segment, it is exposed to this surrounding soft tissue. Later it is intact near the first genu. So here also the facial nerve is involved. So in cholesteatoma, we have to see the extent of the disease, exposure of the vital structure, ossicular status, all those things. And then we'll see the scan. What are the structures involved in the scan? In the right side, this one. So can come from down to up or up to down, however you want, you can see. So facial nerve vertical segment is intact. The lower part of mastoid aerosol system is intact, but the upper part is surrounded by soft tissue density, and you can see the fistula in the lateral semicircular canal. There is a big fistula in the lateral semicircular canal. Once you see fistula in the axial cut, you have to confirm it on coronal cut also. So this is the axial cut. Go and see in the coronal cut how it looks. This is the coronal cuts. So this is the lateral semicircular canal. There is a dehiscence in lateral semicircular canal. It is exposed to surrounding soft tissue. There is a big tegment defect here. So if you want, you can measure these defects also, how much it is. So here it is some 7 mm defect in the tegment plate. And when you have doubt whether it is cholesteatoma or not, go for the non-echoplanar DWI imaging. We call it nowadays cholesteatoma protocol, where we routinely get done non-echoplanar for all patients of cholesteatoma, whether we are diagnosed endoscopically or not. So we do entire HRCT plus we run 2 sequences of MRI, that is the T2 MRI plus non-echoplanar DWI sequence. So how we do, I'll just show you. Just let me close all these scans. So this is clinically we diagnosed already it is a cholesteatoma, but currently we are doing a large scale study to know efficacy of non-echoplanar DWI imaging, so that all the cases we get the cholesteatoma protocol done. So clinically also it is made, it is very extensive aortic cholesteatoma. Entire aortic is obliterated with the extensive cholesteatoma. So there was no doubt of having cholesteatoma in this case, but as per our protocol, we got the DWI imaging also. So what we do, first we see the extent on the CT scan. So you can see the entire eustachian tube is obliterated with soft tissue density. There is a mild dehiscence in the internal carotid artery. Then when you come up the ossicular chain, these 2 dots are not meeting each other. There is a separation between 2. Then you come up, you can see there is a breach in lateral semicircular canal. There is anterior place sinus. Tegment looks okay. And then the soft tissue, we were already knowing that it is cholesteatoma. But what exactly done in non-echoplanar DWI imaging, I'll just show you. So 2 sequences will be run. So first will be the T2 MRI, and second will be non-echoplanar DWI imaging. So what you have to do, you have to see hyperintensity in T2 image and diffusion restriction in non-echoplanar DWI imaging. That is confirmatory of cholesteatoma. So we'll see first this T2. So here you are able to see the hyperintensity in T2. So hyperintense on T2, and similarly you are seeing the diffusion restriction in the non-echoplanar DWI imaging. Means this is definitely cholesteatoma. It cannot be anything other than the cholesteatoma. So when you do these sequences simultaneously, though I am changing one sequence only, it keeps changing in the other sequence also simultaneously. See, and then when you see the T2 hyperintense, you have to just compare whether diffusion restriction is there or not. Now here definite diffusion restriction is there, so it is confirmatory of cholesteatoma radiologically also. So next comes the schwannoma. So schwannoma, apart from HRCT temporal bone, we require the MRI of temporal bone also, along with the gadolinium contrast, because it will be hyperintense. So see this is the right ear. You can see the anterior canal wall. You can see partly the annulus of the tympanic membrane. There is a big mass which is partly pinkish, partly whitish in color, but it is not resembling the congenital cholesteatoma also, nor resembling the paraganglioma also. So when we subject this patient for scans, clinically also we can make out it is a schwannoma and not any other mass. So right side it was lesion. Yes. So the temporal bone in schwannoma, it will show the smooth expansion of the surrounding bone rather than complete destruction or the erosion. So here you can see the internal auditory meatus is normal, labyrinthine segment is normal. As soon as facial nerve comes out of it, there is a smooth expansion of all the surrounding bone with the large soft tissue mass. So then horizontal segment is also not seen. And then if you compare the vertical segment, so much time you were seeing the vertical segment, but second genu and vertical segment, you never saw so much big second genu or vertical segment. Why it is appearing big? Because it is involving, because of the schwannoma, it is expanded. This canal is dilated. Now I am going down, still it is very big. Now still I am going down. Now you can see the normal facial canal here. It has become normal in size. And then stylomastoid foramen is come. So stylomastoid foramen, the distal vertical segment is normal. The mid vertical segment, the second genu, the horizontal segment, the first genu entirely is involved with the this soft tissue lesion, which is presented with the facial nerve palsy. So it has to be facial nerve schwannoma. How to confirm it? You have to get MRI with contrast done for this case. So T1 fat suppressed MRI. So this is T1 fat suppression is done, and you can see intensely enhancing lesion along the same soft tissue lesion what we were seeing in the CT scan. We'll just keep the scans side by side. See the same lesion. The same lesion which is there in the CT scan, it's showing the hyperintensity on the or intense contrast uptake on the gadolinium scan, and then this vertical segment is also expanded. Coronal also you can make out. See this soft tissue lesion, and then vertical segment is also involved, but distal part is intact. Then sometimes you may get cases of Petrus bone congenital cholesteatoma also. So clinically it was a white mass behind the tympanic membrane, but clinically seeing you cannot judge how much extensive can it be, the congenital cholesteatoma. So you have to get the CT scan done to know the extent. So now this is the congenital cholesteatoma. Suppose you are not sure whether this is congenital cholesteatoma or not, and you don't want to subject patient for MRI, that is non-echoplanar DWI imaging, because patient is poor or some financial matter, you just want to get CT scan done, but still you want to diagnose it as to be cholesteatoma and not the facial nerve schwannoma. Simple thing what you can do is myringotomy and just take biopsy from this lesion, provided you are 100% sure that this is non-pulsatile mass and it is not any paraganglioma. So in OPD only you can just put incision over this part, take out that sample, it has to be definitely cholesteatoma. If you want to avoid patient subjecting to the MRI. So we'll see scan. Oh, I opened too many scans. I'll just close it. Yeah, so this is the scan. Clinically, it was looking that it is sitting in the middle ear only, but when you do the CT scan, you'll come to know the extent of this. So again, from down to bottom, or sorry, down to up or up to down, however you want, you can go. So see the extent of this soft tissue lesion. Endoscopically, we were seeing only this much part. That part is also eroded the jugular bulb as well as the internal carotid canal also. Plus, when you are going up, it has destroyed entire cochlea, it has destroyed entire labyrinth, it has destroyed even the internal auditory meatus. See, internal auditory meatus is not seen only, and it has gone and involved the petrous bone also. So this is the very extensive cholesteatoma, and even here the superior petrosal sinus is also exposed. So this is very extensive petrous bone cholesteatoma, which is presented as a congenital cholesteatoma, white mass behind the intact tympanic membrane. Clinically, it was looking limited to only middle ear, but when you subject to scan, it has eroded the jugular bulb, internal carotid artery, the entire cochlea, entire labyrinth, No, labyrinth was not involved in this case, but cochlea was involved because labyrinth is normal here. Lateral is normal, superior is normal, posterior is normal. Internal auditory matters and petrous bone was also involved. Then next is anomalies I shown you already. Paraganglioma. To label it as a tympanomastoid or tympanojugular, scanning is a must. Contrast-Zenon CT scan or MRI with gadolinium. MRI with gadolinium is a gold standard for any type of paraganglioma, and CT scan is necessary to label it as a tympanomastoid or tympanojugular paraganglioma. So tympanomastoid means it will not be involving the jugular foramen or the jugular bulb. So clinically, all of us know how this tumors looks. So this is the paraganglioma. This is sunrise appearance or sunset also it is called. So there will be bulge coming from the hypotympanum and it is occupying the middle ear. So it looks like sun, rising sun or sunset sign, both are true. So we'll see the scan, but on the clinical picture only, it's difficult to label it as a tympanomastoid or tympanojugular paraganglioma. So what you have to do, you have to get CT or MRI done. So we got CT done, that was left ear. So we'll see the left ear and see the jugular bulb. So see here, the jugular bulb is entirely intact, the crotch is intact, the jugular foramen is intact, means this is not glomus jugulaire or correct nomenclature tympanojugular paraganglioma. So this tumor is sitting over the promontory. It is sitting over the promontory, is entered to the handle of malleus, down it is going into hypotympanum and then it is stopping there only. So there is no extension in the jugular foramen, neither it is arising from the jugular bulb, nor it is eroding the jugulocaroticoseptum or crotch, nor it is doing mouth appearance in the jugular foramen. So this is the case of glomus tympanicum, or properly called as tympanomastoid paraganglioma. It is not involving the jugular foramen. So tympanojugular paraganglioma, we will see now CT scan. Okay, so we'll see which side is the lesion. Yeah, it's a lesion in the right temporal bone. So again, trace from down, go to jugular foramen. So this is jugular foramen area. See for crotch. See, crotch is not there. The moth-eaten appearance, the Phelps sign is there. The jugular foramen is eaten out irregularly. It is called moth-eaten appearance. And then from there, this tumor has come to the middle ear. So this is glomus jugulaire, or correctly called as tympanojugular paraganglioma. So I think we are done MRI also in this. I'll open MRI. MRI with gadolinium is there. So left side lesion. So when you are seeing these sequences, you'll see somewhere 20 images, somewhere 50 images, somewhere 100 images, somewhere 160, 210, like this number of images. So whichever sequence is having maximum number of images, that image you have to open. Others are distantly placed images, you cannot make out properly in that. So here I'll see where it is. Still it is coming down. And it should be T1 with contrast image. So this is the sagittal plane. You can change it axial plane if you want to see in axial plane. I want to see it in axial. I made it axial. Then I'll go to the jugular foramen. Here you can see the typical salt and pepper appearance. So paper means dark areas. That will be the voids of the blood vessels of the tumor. And the entire tumor is taking up contrast, that is called as salt. So this is called salt and pepper appearance. So you can see area of intense enhancement along with the voids in between. Intense enhancement area is a tumor or hemorrhage products. Those are called salt. And this voids of the blood vessels, those are called pepper. So salt and pepper appearance. Here it is more prominent. You can see tumor blood vessels supplying the tumor. Yeah. So this is the intensely enhancing lesion, and it is showing the voids in between. Salt and pepper appearance. So if it is intensely enhancing or not, you can just compare it with carotid. So this is the carotid. This is void of carotid, and this is the carotid flow in the horizontal petrous carotid. So you have to just compare this intensity with the tumor intensity. So see, tumor intensity and that carotid intensity is almost same. So it is intensely enhancing lesion with the voids in between. Diagnostic of tympanojugular paraganglioma. Last I'll come to skull base osteomyelitis. So extent, contrast enhanced CT scan, MRI with gadolinium, and nucleus scans are done for the skull base osteomyelitis. Not possible in all patients. So at least you should have get done the plain CT scan, because I told you the use of abdominal window in the beginning of my lecture. So we'll see whether we can apply that abdominal window principle here on just a plain scan. We'll not go for contrast also. We'll just try to see what is the condition of the plain scan. So this is the plain scan. Make it CT abdomen, and visually I think everybody can appreciate the flat plane here. This fat plane is obliterated than this side. So here you can see more areas of grayish color in between the muscles. So we'll go to muscle levels. So go to the pterygoid plates. Pterygoid plate, this is the lateral pterygoid plate. So this is the medial pterygoid, lateral pterygoid. Here will come the temporalis, and this will be the masseter. So here see, these fat planes are obliterated. Why obliterated? Here what has happened? This lateral pterygoid is inflamed. See, this side lateral pterygoid is this much only, but this side lateral pterygoid is inflamed. That's why it has compressed the fat plane here. Fat will be there in this infratemporal fossa, that is compressed. So whether it is true or not, just go up and find out whether disease is this area or not. So we'll go up and we'll change to our default window of bone, and we'll see the mastoid is entirely involved here. The petrous bone is involved. It is irregularly eroded. There is a soft tissue density lying in the tympanic plate and the floor of external auditory canal, which is going anteriorly. Means on the plain scan, we have not done any CT, this one contrast also, not MRI also, only on the using CT abdomen window, you can make out there is an involvement of infratemporal fossa in this particular case in the right temporal bone. So if you see in contrast, just will check in contrast. This is the contrast. So when you see in contrast, again same thing, you can make out the fat planes are obliterated. The normal side, left side, it's more fat, and this side fat plane is entirely obliterated. Sometimes this skull base osteomyelitis can be so much extensive, you can see crossover of the osteomyelitis to the opposite side, from one side to other side. See this case. So you see the involvement, so much extensive involvement. This is the right temporal bone osteomyelitis, which has involved the entire right infratemporal fossa. It has crossed over through the nasopharynx From one nasopharynx, it has traversed to other nasopharynx, and from there it has gone to the other infratemporal fossa also. So this is very extensive case of osteomyelitis culpis. So like this extent can be made out. Then inner ear scan is mandatory. All cases you have to do inner ear scan. Why means one patient presented to us with ADOM with type of history of dengue, typhoid, malaria, all three diseases he had in his childhood. So we are thinking that it may be damage to the cochlear nerve because of all these viral diseases, and he has lost his hearing. It was a profound hearing loss with ADOM in this ear. But look at the scan. He was having cholesteatoma also. Later we operated for cholesteatoma. Look at the scan. I'm just running through this scan. See, there is very gross anomaly is there in this scan. I told you whatever is anterior to the internal auditory meatus is cochlea, whatever posterior to it is vestibule and the semicircular canal. So see this internal auditory meatus. There is nothing enter to the internal auditory meatus, and posteriorly all is dilated. The vestibule is dilated. Means this case the cochlea is absent. See, there is no cochlea in this case. No cochlea. This is not cochlea end. This is the vestibule which is dilated. See this. This is the vestibule which is dilated. Cochlea should be in this region. So this patient presented with absent cochlea, with very extensive disease of cholesteatoma involving the tympanic plate and everything. Clinically, we were thinking that he has lost his hearing because of the typhoid, dengue, and malaria. But unfortunately, it was a congenital deafness because absent cochlea. So this type of cases you cannot rehabilitate the hearing also. So that's why the imaging of inner ear is mandatory. Then few words about the cochlear implant. What are the things we see in the cochlear implant? You have to see the thickness of the skull bone. That doesn't matter actually, because while drilling also you can make out whether dura is exposed or not. Then mastoid pneumatization is very important. Corner septum presence or absence can trouble you. Corner septum, if it is present, it can trouble you. Then the sinus plate, dural plate you have to see. Then high jugular bulb. In these cases, if it is high riding till the round window, it can trouble you. Ossicular status to rule out any other anomalies. Round window status, facial nerve and facial recess cells you have to see. Inner ear structures you have to see. Then internal auditory meatus, MRI is very, very important. Endolymphatic sac and vestibular aqueduct, and other pathologies like CSOM, cholesteatoma, and otosclerosis. So out of this, I have covered almost everything. Only thing I want to stress here is the internal auditory meatus MRI. So we'll see this MRI, and we will see how to reconstruct the internal auditory meatus to see all the four nerves. So we have to go in the cis sequence. Find out the cis sequence. So already here all workup is done. See, cochlea is normal. Left and right, all semicircular canals are normal. Then incus ear long process was necrosed. Left side, everything is normal. Facial nerve course is normal. So we have to check now clinically, CT scan wise, the cochlea is normal, the internal auditory meatus is normal. Now we have to check whether the internal auditory meatus, the nerves are normal or not. Yeah. So this one is the MRI. So in MRI, most important is the acostofacial bundle, that is the internal auditory meatus along with its nerve. So this area is very important for us when you are planning for the cochlear implant. We have to see how is the nerve diameter inside this. So I told you the cochlear nerve is the biggest nerve, followed by the facial nerve, followed by the vestibular complex. So we have to make a sagittal oblique reconstruction of this part so that we can see all the four nerves, like those four dots we should see. So what you have to do, we have to go 3D MPR, open, go to this complex, turn your plane, and go to sagittal. Go to sagittal plane, large. So you can see already all three nerves coming into the picture. Yes. So the anterior inferior is the cochlear nerve. I told you it is the biggest nerve. The diameter varies from 0.9 to 1.3 mm. Here, just for checking, we can just check whether it is adequate or not. So it is 1.07 mm. Then next comes the facial nerve. Diameter is from 0.8 to 1.1 mm. This also will just see. Even visually, you can make out that it's a little smaller than the cochlear nerve. So biggest is the anterior-inferior cochlear nerve. Then next is the anterior-superior is the facial nerve and vestibular complex posteriorly. So this is I made roughly by changing the axis. Radiologists, when they will give you spoon feed. They will form this sequence and they will give you. So here you can see the internal auditory meatus. Yeah. So again, same thing. Visually, you can make out the anterior inferior nerve is bigger diameter than rest of the three. See, this is the cochlear nerve. This is the facial nerve and vestibular complex. So superior and inferior vestibular nerve. This is one side, and they must have given other side also. See, this is the other side. So anterior inferior cochlear nerve, then the facial nerve and vestibular complex. So once the CT scan is normal, the cochlea is normal on CT scan, you have to go and see any abnormalities in the internal auditory meatus. So this I tried to cover everything, whatever I was knowing. I have not left anything which is known to me. So I hope you have understood it and you will try to apply it. This is my WhatsApp number and email IDs. If you want to discuss some scans, I always love to discuss scan. You can send me. Whenever I have time, I can go through and I can reply you back. So I'll thank Royal Pearl University and Professor T.N. Janakiram sir for giving me this wonderful opportunity. I think I have not wasted anyone's Sunday.
Can you show yourself? Just stop screen sharing.
Yes.
Yeah, Dr. Nilesh, I think this is the first time that anybody will be listening to a lecture for more than 5 hours on CT temporal bone. Hats off to you, boss. Really hats off.
Thank you, sir.
Show your complete passion in reading a CT temporal bone. Really a big salute. And also, I knew that this will be the best. That's why I approached you. During AOICon, I approached you because the amount of insight you have, nobody has got it, at least to my knowledge. And really big salute to you. Thank you so much. This will be there on Royal Pearl ENT University channel. And anybody can watch it. I'm sure everybody will love it. I think it's around 4 hours, 45 minutes video. 15 minutes we had a break because of tea time. But till now, people are still watching, means that itself shows how much of, in-depth knowledge you are given. Just a small announcement. We have, for the Royal Pearl group, we have one more Zoom meeting. See, we are not stopping. We are going on doing academics. This is one thing. And we are having a foreign speaker who are all there in Royal Pearl group. You can stay back. We are going to have a separate Zoom meeting. Then second is we are also having Dr. Monish Grover. I have asked Dr. Monish Grover, who is to me, in my opinion, the best in implantology CTs. And so he has consented to actually give some lectures. And also we'll be bringing some good lectures on snoring and sleep apnea from both Indian and foreign dignitaries. So we're going to have a lot of academics in this channel. Stay tuned. I'm sure Dr. Nilesh has made his mark just like a bullseye, showing that there is nobody who can really, talk for 5 hours continuously on a CT, and that too the kind of, involvement you showed, clicking. Even now, I'm having a hangover of clicking in my ear. Really beautiful, boss. Really hats off to
It's
you.
always better to have own collection, sir. Now also I connected my 2 4 TB hard disk to my laptop. That's why it was taking so much time to load.
Really super, boss.
Yeah.
But if you see, I'm telling you, how many 4TBs we have? Sure. We have around, I think, 25 4TB hard disks lying here, full of academics. We are bringing all that into one channel, means you understand how much of I'm trying to open up ENT to every single person in the globe. This is my only intention.
After this, and to keep it on YouTube channel.
Yes.
Everybody cannot store data. So YouTube.
So I'm going to bring all this 20-25 4TB artists inside YouTube, so that for generations this channel will be, it is today maybe 200 might have seen or 500 I might have seen. I don't even care. At the end of 10 years, you see the whole thing will become like a big logbook. It will be around 100K views and things like that. I'm not bothered about views also. I'm bothered about how from our heart our teachers teach. And this is what I really want. And I want you are one such teacher. Do you have any other lecture you would like to talk about in otology which you want to talk? Because this I want to exclusively dedicate this segment to you. You have any something like diagnosis for postgraduates you have?
Yeah, sir. Diagnostic, even facial nerve is good, sir. How to diagnose and treat the facial nerve cases.
Okay, so we'll do one thing. No. First, we'll start like this. We will just go on for just diagnosis of common diseases in the ear. You have written a book, no?
Yeah.
So you will be having a lot of pictures.
Yes.
So you just give us the common diagnosis for sake of postgraduate or consultant.
Yeah.
Some people, I'm telling you, they don't even know how to diagnose meningitis, boss. They're diagnosing granulation.
Yeah. Correct.
So I'm sure you will be also coming across certain things. So they are not sure whether it is, keratosis or is it cholesteatoma. They are a little lazy about it.
Thank you.
So if you can do one lecture, I will contact you on that. So that will be your second lecture. And third, your lecture, if you can give on facial nerve, it will be very good. So 3 lectures I'll get from you, and that will be exhaustive. I will get your dates. I have to now book you. Everybody will start booking you. You are a big guy now. And thank you so much, my dear friend. And really hats off to you for your enthusiasm. Royal Polite, stay back. You have the next lecture going to start. Thank you very much.
Thank you very much, sir. Thank you very much for inviting. Thank you, sir.
God bless you. God bless you.
Thank you, sir.
Yeah. How do I store it on YouTube, my dear friends?